Good afternoon and welcome to today's webinar, Leadership Mixtape, Amplifying Your Team's CMS Success Strategies, presented by QRM. QRM is an in-house rehab management company that works with skilled nursing facilities all across the country. We also provide MDS education and training, medical review, compliance assistance, and marketing services. Visit qrmhealth.com to discover more about QRM and its services. My name is Amy, and I will be your moderator for this session. Now, I'm pleased to introduce to you our two esteemed presenters who will be sharing with you their expertise today. We have Mark Heider, VP of Reimbursement Strategy and Education for QRM. Mark has 30 years of experience in the skilled nursing space and a deep understanding of the challenges and intricacies facing our industry today. He is passionate about educating the next generation of healthcare leaders and is committed to improving patient care and operational efficiencies in the facilities we support here at QRM. Next, we have Stacy Grondel, Director of Clinical Reimbursement for QRM. Stacy has more than 19 years of experience in long-term care and is recognized for her expertise in the RAI process, audits, appeals, clinical processes, and clinical reimbursement. Stacy has served on the APAC and Expert Advisory Panel since August 2019 and has been instrumental in continuing innovation and quality in long-term care. Today, during the webinar, Mark and Stacy will cover the strategies for success with the upcoming MDS changes. So we just want to thank you again for joining. We're excited to have you here. And just a reminder, the handouts for this presentation, so you can follow along on screen or at another time, is available in the chat bot feature at the bottom of the page. Now I'll hand it off to Mark, who will get us started today. Thank you.
Thank you, Amy. It's great to be back and spend this time with you. Welcome, Stacy. Welcome back.
Thank you. Thank you. Excited to be here.
This is a good opportunity for us because over the last several months, we've talked so much about the nuts and bolts, the technical pieces of the changes that are coming up. And at first it was the proposed rule, and then we waited for the final rule, and most of the proposed rule was adopted into the final rule. And then most people will wait until about this time of year to really focus on implementing changes because you are waiting for that final rule. You want to make sure the changes you make are the appropriate changes and that you don't disrupt your processes too many times. But this is a little different. Now, we've got all the technical pieces, we've got all the information we need to get started, but what do leaders do with it? Why is it a different approach, or what makes it different? And so we're going to kind of go through much of the similar information that we've presented in the past, but take a leadership slant at that. Why is it important to leaders? What should you do? And some of this really won't give you every answer you need. It's not every answer because facilities are so individual, and you can sit down with one facility and say, you need to do this and this and this. And they look at you and say, oh, Mark, Stacy, we're different.
Yeah.
Which facility hasn't said that?
Right.
We're different.
We don't do things like that.
Yeah, because we assign our roles a little bit different. We don't have that person. We have this person instead. And we have this other person that does it really well. That's what makes facilities unique and individual, and that's okay. So I don't want you to think there's anything wrong with it. And that's certainly not a derogatory comment. It is what it is. We have very small facilities. We have very large facilities. We have facilities that have, more access to staff than others. And so we understand that. We also understand there's, different regulations, different positions that are mandated by states. Some states may say that you have to have a staff development coordinator, and those type of things. So you have additional people to do it. So getting back to the point, we're really looking at this from a leadership standpoint. And we want you to be thinking in terms of, okay, in my situation, with my team, with my processes, what do I do with this information? Because here's the thing. You're the leader of the facility. If you're the administrator, you're the leader. And one of the things that's always surprised me through my career is how many leaders in skilled nursing facilities don't understand the business. And it's so easy to people call it delegate. I'm going to delegate all these things, but in true delegation, we're not just giving it to somebody else and then letting it go. in any type of delegation, we are assigning it to somebody who's capable of doing it and doing it well. But then it's still our responsibility to follow up and ensure that it happened like it was supposed to. But in skilled nursing, it's so easy to say, hey, I've got this great DON, I've got this great MDS nurse. So I just give it to them and they do it with what they will and hope that they're doing the right thing and hope that you get the right outcome. And quite frankly, we don't want to hope. We don't want you to have to hope. We want you to be well educated. And our expectation is, as leaders, you'll take this information and you will lead your team through these changes, which means you'll understand them, that you're paying attention and you're thinking through your processes and that you're doing the right thing for your team to ensure when October 1st comes, smooth transition.
All right. And we really want you today. One of our goals is for you to write down the things that you're wondering, ooh, I wonder how we're going to do this at my facility. Or have we talked about this? So as we go over these things, and we're going to pose some questions to you, and we want you to be able to take that back and say, hey, how are we going to meet this regulation? How are we going to ensure this is happening? Because ultimately you're the one that's going to be responsible for that. So you've got to have a process in place, and you can have those experts, your expert MDS nurse, your expert social worker in your building, but then knowing what they're doing and being able to have them articulate to you what they've come up with, and you guys can troubleshoot and come up with strategies together if they haven't thought of anything yet.
Absolutely. Absolutely. I love to keep lists. I've got to-do lists everywhere. So start your to-do list, get that piece of paper out, your pen, whatever you're using. Let's talk about our true objectives that we listed out. First, we're going to talk a little bit about the final rule. Second, we're going to talk about the civil monetary penalty change in policy. Then we'll move on to the staffing mandate update. Talk about section GG from a leadership perspective. And here's the thing. If you're tired of hearing about section GG, you're going to have to gut up, because you're going to hear more about section GG over the upcoming months. And it's not going to go away. In fact, you're going to want to pay attention. You're going to want to figure this out because it's connected to a lot of other things. We're going to talk about the SNF quality reporting program, the value-based purchase program. We're going to talk about some potential traps, and then we're going to wrap it up. So should be a good day, should be a good hour, and we're going to jump right into it. Now, we knew that when the final rule come out, had come out, and speaking English today, that they would give us our rates. So they're releasing our rates, and everything should be in line with that. We saw that there was a 4% net increase, which was $1.4 billion, including that adjustment calibration. And that sounds great, but just like everything else, if you think about a 4% increase, if you're getting a 4% increase, you better be able to hold on to that 4% or it doesn't go very far. So the $1.4 billion, I think, is a little deceiving because that's not what each of us get. It's about a net 4%, which isn't evenly distributed. You got the rural, you got the urban, you've got the different rates and different locations. There were some changes to the ICD-10 code mapping. That happens every year, and luckily CMS, puts out a full change list. One of the things that I always go back to is there are so many nurses that have cheat sheets that list down their top 10 or 15 or 20 codes. This is a good time for your leaders to be challenging your nurses and say, let me see that cheat sheet. Have you updated? Number one, you really shouldn't use a cheat sheet, but if you do, are those codes current? Because you could start running into some problems.
I would even take it one step further, Mark, and I would say, as a leader, have you ensured that whoever's doing the coding in your facility have an updated coding book? They're not something that you can still have the 1998 version and still using. They update this coding book quite frequently. So making sure that your staff has the updated coding book, because it'll include things that they can't find on the internet. So important that you are providing that resource for them. It's not that much, but it will make a huge difference on ensuring they're getting accurate coding and in turn getting accurate reimbursement.
That's true. And that's $100 well spent.
Yes.
And if you look at it and people will say $100, we can't afford $100. You can. You don't want to make mistakes. You want to be reimbursed appropriately. And everything that we talk about is about getting things done accurately. And that's probably one of your best tools for your MDS nurses is that coding manual, the current coding manual, not last year's. Next was the exclusion of marriage and family therapists and mental health services from SNF consolidated billing.
I like this one.
I do too.
I like this one because we don't have to pay for it anymore.
Exactly. This is a big one for us. And the interesting thing is so many facilities treat a high number of mental health residents. We know we have a lot of patients who have those needs. Anytime there's a carve out, anytime there's an exclusion, we should know about it. So I thought this one was worth mentioning. We know there were changes to the SNF QRP and value-based purchasing programs. And we'll go through those a little bit later, so we won't go into it right now. And then we'll talk about the waiver process for civil monetary penalties, which is a big change. And then there are several other items that are not effective necessarily until the fiscal year of 2025 and 2026. But it's important that we start looking at these things because I think we all know it takes a while to adjust. And in some of our other webinars, we've talked about some of the penalties and rewards. And when you start talking about measurement years or performance years and all that other stuff, your baseline measurements, there are 2-year gaps. There's a 2-year gap between when they're measuring it and then when they're holding you accountable. It takes a while to change these programs. So while this seems a little premature at times, it's not. You got to start talking about these things now so your team's ready and moving by the time that they're in place. Of course, we put the final rule up here, Federal Register. And here's the thing, and we go through this all the time, and I'll go to my grave saying this. Know the rules. Don't just use the rules of thumb. Don't just wait for somebody to tell you you're doing something wrong. You know, one of our colleagues was talking about the Federal Register and the final rule, and she talked about she reads it every year. It takes her a while. She doesn't read it in one sitting, but she'll read through it and she'll digest it. And then, of course, our professional organizations, you know, American Healthcare Association, APAC, and a lot of other groups will write white papers or summaries. And they're all good, but it's good to have the Federal Register. It's good to look and make sure that you're pulling the right information. Use it as a source for your information. You're not just going off of rules of thumb and hearsay. The one of the big, I don't know if we want to call it surprises, but it was a good thing, that core Q, that resident survey, it's gone. It's not adopted. Why did it leave it on here? A couple of reasons. One is because the threat was that you were going to have to engage a contractor and pay them to provide these surveys, which would have been quite a bit. When we're looking at that 4% increase, that's where part of your 4% increase would have gone, is to that contractor. And the government's saying that they're still going to find a meaningful measure. So in my mind, I'm thinking, number one, I need to be involved and I need to help to guide the legislation that's going to come out, that's going to direct us to do something. The other thing is there a pay for, if that's going to happen in the future, and they're saying it probably will. How are we paying for that? The third thing is we should be taking the temperature of our residents as far as how they feel about our services. It's one thing to think we're doing a great job. It's another to hear it from them.
Right.
Quite frankly, one of the most problematic situations I see in facilities during survey are unhappy residents and unhappy residents' families. So while this isn't legislated, we don't have to adopt the core Q. We need to start shaping our policies, shaping our behavior to acknowledge they're going to take a measurement. And the sooner we start applying that to our logic and our processes and teaching our facility staff to do this, the better off we're going to be when it's adopted. Now, the waiver for this, the process for the civil monetary penalties. I hate talking about the CMPs, hate it. But we know they're there. And we know from time to time, facilities are cited, and there's a civil monetary penalty that's applied to it. So one of the things the government decided to do is, rather than you having to apply for a waiver, if you don't respond within the time frame, they're going to apply that waiver to you. They're going to apply the 35% adjustment down, and you only have to apply or send in a letter if you're going to request an appeal, which makes it kind of nice, because if you're not going to appeal it, you might as well get 35% off and move forward. Yeah. And, CMS is pretty vocal about how few facilities really appeal these type things, whether it's a CMP or anything else. A lot of facilities don't. So this is a good news for us. One less thing that you have to pay attention to. If you're not going to appeal it, you just let it go. You'll get the 35% off. To me, it's a good thing. It's not a bad thing. One of the things that came out, and I think everybody was surprised a couple of years ago when the president was talking about staffing in nursing homes at the State of the Union, and that he was going to have a staffing mandate. That couldn't have come at a worse time, because we were in the middle of the pandemic. We were losing staff left and right, and it was an uncontrolled thing for most facilities. People were just leaving the industry. They were staying home. They were going into different lines of work. They're doing a lot of things, and to hear that was really disheartening. Fortunately, there was a lot of feedback given by HCA, Advion, APAC, and almost every organization that we deal with that was requesting that they back off that unless there's a pay for. How are they going to pay for it? And there really was a resource there. So it was nice that
can't hire staff if there's no staff.
Exactly. It's like, I would love to, but give me some applicants. Now, CMS was a little bit quiet about this, but don't think that they didn't do something about it. So they're a little bit quiet because they said in sometime in the spring they were going to release a statement, and that never really seemed to materialize. But it wasn't necessarily good news or bad news, because they included the staff turnover measure in the value-based purchase program. So there is a measure there, even though it's not necessarily what people had feared. And the staffing turnover is also included in the 5-star program. So it's been there for a while. And one of the things we keep going back to in the 5-star program is that's your Yelp. That's your rating to the public. And where 20 years ago, people didn't really pay attention to it, I guarantee everybody goes to it now. Most people will go look your facility up. They will look at your star rating. And quite frankly, they don't know how to interpret your star rating. And you can dig down deeper, which is what I've done here. But if something pops up like this, and I didn't intentionally pull a facility with 2 stars, but afterwards I thought, I'm glad I did, because if I were just a casual observer and I was going to care compare, and I pulled up 2 stars, 2 stars to me looks bad. Does not matter how you sugarcoat it. And so there are 2 things that are happening here. Survey is tough. And if I have a low star rating on my survey, and then I have a low star rating on my staffing, I better have a really high star rating on my quality measures. But I'm still going to be a little skeptical. So there are some consequences to this. One of the consequences may be we don't get in provider networks and we don't have the ability to admit their residents, because we don't have a 3-star or higher overall, unless our quality measures are high enough to pull that up. So while we didn't get that staffing mandate that people are afraid of, there are still staffing implications. So we still need to be very aware.
Right today.
I did get it right. Yesterday it was not coming out. I should avoid it, but you live and learn. Okay, so Stacy, tell us about section G. G.
Yes. So with section G, what I really want to focus on today is, as a leader, what do you need to know for section GG? So we know section G is being eliminated from our regular item sets. So what we're going to have for our patients. And we do know that there are a few section G items that are going to be transferred over to GG. And there are, quite frankly, a lot of the items that were addressed in section G that are already in GG and have been in GG. And we're going to talk about how how that poses a problem or a potential problem for you at your facility. That Section G items are currently used to calculate our ADLs and our quality measures. And so understanding what that was impacting before is going to be important for understanding how GG is going to impact several different things, right? GG has been around since 2016, but it hasn't had as much attention as it has over the past couple of years, and it's going to continue to be really heavy. That Section G that we're used to has been so important over the last, since the 80s. It has been a huge part of SNF. And so really now taking that and transitioning it over to GG is huge, right? So we're going to talk about how that's going to impact your staff, how it's going to impact your aides, what you need to think about as a leader of your building, and what that could potentially mean for you and your staff. So CNAs, since 2016, probably for most facilities throughout the country, have not been documenting on Section GG items. They've been doing G because we've still had to do that for our item set. We still needed G. So a lot of facilities made the decision, instead of confusing them and having them do GG and G, we'll just have them continue to do G, right? Now, GG is going to be our main source for all of our payers. However, some of your states have chosen to keep the RUGS-based Medicaid reimbursement system, which requires us to still do Section G on that OSA item set, right? Or some of them are using some sort of crosswalk. There's all sorts of really creative ways to still get our Medicaid reimbursement using the old system.
So you're saying Section G is going away, but you're saying it may not be going away, right?
It's not going away. It wants to stay there. Section G, it's been around for so long, and it's not going out easily. It's making a big bang.
I just want to make sure people understood that. Section G
Yes.
is being eliminated from the MDS
For most items.
for most item sets.
Except for your OSA if your state
Exactly.
requires it. So that poses our problem. How do we get our staff to document G and GG items? So if you are one of those states that's requiring Section G to still be included, how are you as a leader making sure that we're collecting the G items and the GG items? Does your staff know the definitions? How are you going to figure out how to get that documentation, their inverse scales? So what was a 4 was dependent with G. Now our highest number is 6 is independent. So they're opposite of each other. So if your staff is just used to hitting a 4 or a 3, are they going to continue to do that? Are you going to allow your staff to do GG documentation, your aides? And if so, have you talked to your EMR? How are they going to do that? Are they even going to include it in their charting, whatever you call it, their POC or whatever they call it? Are they even going to leave that as an option? So these are things that you need to think about as a leader. Do you know how you're going to gather that information? Because you have to have that information to be able to code the MDS accurately. And that's always our goal, is accurately. So have you thought about how you're going to get this information? Are you even going to have your aides do it? Or instead have other disciplines within your facility gather the information? I would say one of the major differences between G and GG is G, you could gather the documentation for your aides, you use the rule of 3 and code it on the MDS. For Section GG, somebody has to be able to gather that information and use clinical decisions to determine what that usual function is. You can't just say, oh, we'll use the rule of 3. This is how many times it was charted. You have to have somebody who analyzes that per the REI manual. So now we're going to go into some pay for performance programs. So I just want to touch base real quick on how this is the takeaway message, right? It always starts with the care that we're providing. It's good to know the rules of the game. It's good to know what's happening with the value-based purchasing, with the SNF QRP, with the 5-star. You have to know those rules, like Mark talked about. but it all starts with that care. So understanding the rules, but care is what determines what we do in our facilities. That's what determines the decisions we make. But we have to understand how those decisions will impact us financially and with these quality incentive programs. And then this is the hardest part for people, is to capture that care in documentation. What did I do? What was the patient's response to it? So documenting that. And then it gets coded on the MDS. And you'll talk, if you know have had any experience with me at all, you know that my soapbox is gathering information during that ARD period. So we're providing the care and documenting it, but while we're in that look back period, we're reviewing the information to make sure that it's accurate and that we have everything we need to accurately code that MDS. So we have our 5-star program, and it impacts, this is what's on the Care Compare, is that this 5-star program, and it impacts so many different things. Mark talked about maybe potential resident or resident families reviewing it, but you've got your insurance companies, your ACOs, your bundle payments, your hospitals, your physician groups. Everybody's looking at this, and it is public facing. So it's all of the information to show. And essentially what this says to the public is, this is the type of care we're providing. This is how good we are at taking care of patients at our facilities.
So if I were an administrator, how often would I be pulling this up?
Well, your 5-star rating, so each month they come out with a new 5-star rating, but your quality measure portion is only going to change once a quarter for your MDS, and 6 months for your claims. Your survey portion is going to change anytime something happens at your facility. So if you have new citations, if you had a new complaint survey that was substantiated, that's going to change. So as an administrator, I would say checking your Care Compare once a month, make sure things are accurate, make sure that you know what other people are seeing about you. You know what you're advertising. So we're going to talk about the SNF QRP program. So these are the 16 measures that will be for fiscal year 2024, which means October 1st of 2023 is when these 16 will still be in place. So you have several that come from the MDS, a few that come from claims-based, and a couple that come from NHSN. So what the quality reporting program is, and go ahead and change the slide, shows what the quality reporting program is just reporting. We're reporting information. So with this update, they said, okay, we want to change things up a little bit. We want to make sure that we are gathering information for measures that matter to our consumers, measures that matter so that we can really see what's going on in these facilities. So they adopted 2 new measures. They removed 3 measures. They modified 1 measure, and then they changed the reporting threshold. So we're going to talk about each of these things a little bit.
I'm going to go back that last slide just for a second, because one of the things that came out this last week was an article or a transmittal from CMS that talked about the surveyors looking at vaccinations, and that they're no longer going to be looking at and using those part of the survey process. But what I don't want people to do is think that vaccinations for healthcare providers are not going to be looked at. They are, and you can see at the bottom of this form, those are 2 or at least 1 of the measures down there. 2 of them are vaccination, 1 is for healthcare personnel. You want to make sure that they understand that they will be looking at it for your SNF QRP, for your COVID vaccination amongst healthcare personnel. So just a little clarification there.
And we'll talk a little bit more about the vaccination here in just a minute. Okay, so the first one we're going to talk about, yeah, go ahead.
Oh, sorry.
Sorry, communication barrier right there. So with the SNF QRP, they added the discharge function score, and this one they're going to compare, CMS is going to say, this is what we expect this resident to be at discharge. So they're going to compare what they were when they came, compare what they were at discharge, and see if you met that criteria. Okay, and we'll talk more in depth here in just a little bit about that discharge function. And then with the COVID vaccine, just like Mark said, even though this isn't going to, our surveyors aren't necessarily going to be looking at this, this is something that now is part of the SNF QRP. So they are looking at the residents and your staff who have received that COVID vaccine and are up to date according to CDC. So it's really important that we're looking at these things, even though they're I feel like they're kind of doing like a smoke and mirror. They're like, oh, we're taking it over here, but look out, it's over here, it's over here, right? They're trying to trick us here. And then, like Mark already talked about, the core Q is not happening, but really emphasizing that resident satisfaction, that patient satisfaction. That was CMS's point behind that, is to really kind of force us into being able to monitor this and know, and like Mark said, get that temperature for how our residents are doing. But now let's dive deeper into this new discharge function score. So it impacts so many different areas, and it impacts your patient satisfaction. It's going to impact all of these quality incentive programs. It's going to impact what's being publicly reported and what people are seeing. And if you don't have this good discharge function score, what's that saying to people? You're not doing a good job. You're
Absolutely.
not helping these people get better. Why would I want my mom to go with you when you haven't met these thresholds? You aren't making them get better. Okay. So it is included both in the SNF QRP and the value-based purchasing. So super important. It's now this one measure is impacting so many areas. So if you're good at it, it's a good thing because you're doing well in those areas. But if you're poor at it, not so good.
That's
right?
a big problem. It's a
big
compounding problem, right?
Right, exactly. So they are going to start collecting the data this October, but then your performance year will be next October, October 1 of 24. Like I said, the quality reporting program right now is just on reporting. So this isn't impacting your, this discharge function score. If you don't meet it, isn't necessarily directly related to reimbursement at this time. But knowing CMS's patterns, it certainly will. So what GG items are going into this discharge score? Those look familiar, Mark?
Really familiar.
This is part of our PDPM, right? We use all of these same areas on our PDPM score. These are GG scores that should be very familiar to you as an administrator. So asking yourself these questions: how are you currently collecting the data at your facility for these items? Is it accurate? How are you validating that it's accurate? Is there a better way of collecting it? Maybe you're not so impressed with the way it's been happening. So this is our opportunity to shift and change who's going to be assessing this information and making sure that it's coded accurately on the MDS. Remember, we're starting with our care, and we're looking at our documentation, and then that's being coded. So just some things to think about. How is it being done, and could I make it better?
As a leader, this is one of the things I'd be keyed in on. I think this is the most exciting change that happened this year, because it is a true outcome measure. That is what they're going to use in the future for determining part of our payment. It's something that's already tied to reimbursement. And so if I'm looking at each of these items, I want to know, with rolling left and right, where did they start? Where did they end? You don't have to be a therapist. You don't have to be a nurse to understand this stuff. You just have to know there's been a positive change. And if I want to change anywhere in the MDS for the positive, it's here. It's on these items. You can track these items. You should track these items.
And I've heard buildings say, well, we're just going to have our team still just code, those 4 late loss ADLs that they've always been doing, because that will translate directly over to GG, right? But for bed mobility in G, it was broken up into 3 different components in GG. So by them saying bed mobility, you don't know which portions of the bed mobility required that assistance. So it's not a direct crossover. So another thing to think about as an administrator, especially if you've made the decision already that we're going to have our A's just continue to document the ADLs like they've always had, how is that going to impact things? So I cannot emphasize enough how important that proper baseline score is. And I saw this all the time, and I still see it, where for those first 3 days, the aides are just documenting whatever they can to get their documentation done. And it isn't until day 3, day 4 that they're like, oh, they need a lot more help than we initially thought. So now our baseline score is showing a lot more independent than they really were when they came in. So really looking at how are we setting our baseline scores? And then what kind of interventions are we putting into place to help them progress? Are they evidence-based? Are we getting therapy involved? Are we getting nursing involved? Are we getting social workers involved? Are we getting everybody involved, looking at the resident holistically to get them where they need to be? Because everybody knows that if you feel like crap, you're not going to improve. You're not going to get better because you don't want to do anything. You don't want to participate. You don't want to progress. And so really focusing on the resident as a whole will help us improve those discharge function scores.
And I really like to see functional activities. One of the things that's absolutely scientifically proven is we improve in those areas that we focus on and we practice. You know, if I want to play tennis better, I don't go practice golf, right? And when I walk into nursing homes and as a therapist myself, I look in our therapy departments to see what they're doing, and it's often unrelated to function. We're not practicing transfers. We're not practicing sitting up to the edge of the bed. We're lifting 1 pound weights and doing bicep curls and stuff like that, which is, it's not detrimental, but it doesn't necessarily get us to that goal. It doesn't get us to the finish line. Exactly. That practice makes perfect. And it's that functional activity that we really should be focused on. And we can go look, we can go see what our therapists and our nurses are working on. The other thing is we have extensions of therapy in our building. Activities should be an extension. Are we doing active activities or are they passive? You know, we're just watching movies, stuff like that. With our nurses, and it doesn't matter whether you have a true restorative nursing program or not active in your building, nursing contributes to that because on a 24-hour clock, your therapist is going to work with the patient how often or how long? An hour? Yeah, an hour and a half. Then they're in bed for 22 and a half hours or sitting in a chair. We really need to focus on those activities that we're being judged on. And CMS is telling you those are the activities that are meaningful to them. So should be where we're doing
to your partners. Yeah. So
Absolutely.
as a leader, asking these questions about those GG items, right? We're getting back to those GG items. Do the staff know the skills? Do they know what they're documenting? Do they know the reason for documenting? Do they know what the patient's goals are? Do they know what you're working on as a team? I would say one of the biggest detriments that I see when I go into facilities is when the leadership has goals and they're working on things, but they don't tell anyone. They keep it tight. And then nobody can help you reach the goals. But if you are loud and proud about your goals and what you're working on, that's when the whole team gets involved and you're really going to see those good outcomes.
Yeah. It's about rounding. Really, it's walking around your facility to see what happened, to see if it makes sense to you. And as a leader, it should make sense to you. You should understand the program.
Yes, for sure. And then we're going to talk about the vaccination. So you've got your COVID-19 vaccination. So resident and patient and the healthcare personnel, right? Mark talked about how important those still are, even though they're taking them away from some areas, they're still going to be there. You know, we said it's a small but significant change. Why is that? I think about our immunization for flu and our pneumovac that's currently being reported on the MDS, and how many facilities across the country are not meeting the metrics for that. And those seemed small and simple, right? So now we're into COVID, the COVID vaccination. So as a leader, what is your current process for administering these vaccines, tracking these vaccines, and documenting these vaccines? How are you doing that currently? Is it going to work? Is it a long-term thing that will continue to work? Or do you have one person run around like crazy trying to keep track of all this and we don't really have a good system in place? So really, as a leader, thinking, okay, maybe we track all of our vaccinations the same way so that we're not using 20 different spreadsheets or 20 different programs. We have one way we're tracking all of these vaccinations. And are you going to track your resident vaccinations the same way you do your staff? Maybe you have a different person. I don't know. These are things that you need to be thinking about as a leader. How is it going to work in your facility? Who could be working this? Is it going to add an extra burden on your staff, or is it something that you could slip in to something you're already doing? Okay. Then we have our reporting threshold. This is probably one of the most misunderstood QRP measure. And what it is it is saying that CMS needs to have all of the information to be able to calculate all of those quality measures that we showed you, those 16 quality measures. Does CMS have the information to calculate those? Okay. So how an MDS counts against you is any of those fields that they use to calculate those quality measures. If there's a dash on one of those, that whole assessment goes against you into that 20%, right? It goes against you. They're raising the threshold to 90%. That means you can only have 10% or less that win against you. Okay. So it's so important that you are not dashing your MDS. I wish we had a poll question here where I would say, what does a dash mean? Do you as a leader know what a dash means? When your MDS nurse is putting a dash, that means, I don't know. That's what they're saying. I don't know this information. I didn't assess this information. I don't know it. And that should be 100% avoidable. And that's what CMS is saying. They're saying there's no reason for you to have dashes. So those items in section GG where the resident didn't do it, instead of putting, I don't know, it wasn't assessed, we tell them why it wasn't assessed. So you have those four did not occur options that you can choose. For other items on the MDS, I'm going to get back on my soapbox. Know the look back period for the MDS. As an administrator, when you're in your stand-up meeting or morning meeting, you say, hey, what MDS do we have that are in a look back period? What information are we still needing so that we don't have to put dashes? And then that way you can follow it up with, okay, this is what we still need. Who's going to do it? When are they going to get that information? So when the MDS nurse sits down to code her MDS, the care was provided, the documentation was there, and now she can code it or he can code it with confidence that the information is there and it is accurate. So as an administrator, know what dashes are. Know how to avoid those dashes. Know the conversations that you have to have, because this one does have a penalty associated with it. And it's a 2% reduction in your annual payment update. That's huge. That could be catastrophic for our smaller buildings. So really important, administrators have a huge role in this portion, making sure we are not dashing our MDSs. The information is there, it's documented, it's accurate during that look back period.
And most administrators are the ones who oversee the MDS nurses, in my experience. A lot of time they report directly to the administrator. You should know this. One of the other things, if I were administrator, I'd be watching for are the number of late assessments, because when you get backlogged, one of the things we've seen in the past is nurses get in a hurry to get those caught up and they'll start dashing. And that is so detrimental to this number. So be aware of that in and of itself. How many late assessments do you have are outstanding?
Yes. So falls with major injury, this is one, it's going to count on, it counts on your 5-star, your SNF QRP, value-based purchasing. This one is not going away. And it does take a long time for it to fall off of your quality measures, because your 5-star quality measures, it has a 275-day look back period. This is a huge one. So as an administrator, what should you be thinking about? We can't prevent every fall. There's just no possible way to prevent every fall. But what is your process when someone falls? Are you doing root cause analysis? Are you trying to figure out how do you have some of those active programs in your building to keep people active so that they aren't falling? Do they have their needs? What is your process? What is your fall process in your facility? How are you handling that? Something to think about as the leader. The transfer of health, this one, I actually really like this one, just because for that continuity of care, I feel like it's so important. Oftentimes our rehospitalizations are related to patients discharging from our facilities and not knowing what they need to do. They've received 20 different papers with highlighting and circles, and they have no idea what medications they're supposed to take and they aren't supposed to take. And so I actually really like this one because it kind of forces us to make sure that we're having that transfer of health information to the provider or the patient so that they can be successful at home. I would say, as an administrator, what is it that you want to look at this one? It's making sure that you have a discharge plan in place at your facility so that your patients are successful. And this will reduce your rehospitalizations as well.
Get them home, keep them home. We're going to be talking about value-based purchase now, which is that whole program about get them home, keep them home. Send them to the community, keep them in the community. That's what this whole thing started off as. And really still a lot of its focus is the rehospitalization. In fact, currently, that's how you're either being paid or penalized is your rehospitalization rate. So we know there were some admissions, there was one that was replaced, and a couple of policy changes. So right now, like we talked about, the first part of this program, the nursing staff turnover measure was added. And it's the same measure that you're using for 5-star. Your discharge function score that Stacy went over, they have the PDPM measures are as part of the value-based purchase. So it's now PDPM, it's SNF QRP, and value-based purchase. And then your long stay hospitalization measure per 1,000 resident days. The concern here for you should be that in the past, almost everything in value-based purchase was for your acute care short stay residents. They're now reaching into your long stay residents and looking at some of those measures as well. And then your percentage of residents experience one or more falls with major injury, like Stacy mentioned. It's again, crossing boundaries. You're either doing well in this or you're really not doing well in this because it will affect you in so many areas. So not to keep beating a dead horse, but nursing staff turnover. We know that you have staffing issues. We know what you're paying for registry and temporary staff to come in. We know that it's a problem. So as a leader, what are you doing about that? What are the things that you control with your retention, with your attracting staff, with you're really being that place that people want to work based on your care?
And I would say, Mark, looking at the things that your staff feel are important, right? As a leader of the building, you may think, oh, pay is the most important thing. We can't afford to pay them. Maybe not, but what is important to them besides pay that you can do? What is it that your staff wants? What's the demographic of your staff? Maybe there's specific things that specific demographic really enjoys or wants. Really thinking outside of the box. How can we retain the staff? How can we make sure that they're happy? And it doesn't always equate to higher salaries. It could be benefits. It could be other things that you maybe have a little bit more leeway on.
You know, it's funny because when I was in college, I had one of the worst jobs ever. I made taffy in a candy factory, but it was a family-owned business. I made terrible money, but at the end of every shift, the owner would come thank us, shake your hand when you're walking out the door. The name was Vern. That's all I remember about it was Vern. He would come shake your hand. I felt good every single day with that job. Stayed way longer than I should have, but I loved Vern and I loved the fact that he appreciated what I was doing.
And he cared.
He did care.
He cared.
He did.
Yeah.
So again, we pulled this up. I just want to reiterate, this information goes to the public. Your staffing, your survey, your quality measures, all goes out to the public on Care Compare.
There's it again, the discharge function score. There it is again.
And it's all about section GG. So when you thought we're going to stop talking about GG, we kind of will, kind of won't. It's about section GG. It's your functional scores in those areas that we went over. So important. If I were an administrator out there right now, I'd be highlighting this area and saying, okay, Stacy told me there are now 2 scales that I'm having to measure, section G and section GG if I'm in a case mix state that's using RUGs as my Medicaid payment. So now how do I think through this and work through this so that I'm collecting the right information for section G, the different information for section GG, so that I'm getting paid like I should on Medicaid, and so that I'm not being penalized for my Medicare, and I'm being paid appropriately for my Medicare through PDPM. This is that big. This is going to affect you on every level. Those facilities who do this well will be much more successful than those who don't. And it starts with the leader. Talked about this a little bit. It's a long stay measure. It's the hospitalization per 1,000 resident days. So if they're going to your acute care hospital, they're going to your critical access hospital, even outpatient observation days, this is a claims-based thing. It will come back. You're going to be penalized if you don't keep people in place. And we'll talk a little bit about this in a minute, but it's important because there's strategies that you're going to want to really implement. So the falls with major injury, again, there are only certain injuries that go into this. The biggest mistake that we see is that people miscode this because a serious injury does not necessarily mean it's a major injury according to the RAI guidelines. Now, if it's a serious injury, you do exactly what that resident needs. Your care plan should be absolutely perfect and inclusive, but it may not trigger for the major injury. So before somebody checks that box on the MDS, review this and make sure it meets one of these 4 categories. It either fits in this or it does not.
And I would say as a leader of the building, that's one of the questions you ask when you have a fall. Did it meet the definition of major injury per the RA manual? If not, let's not code it. We don't want to take credit for anything that we don't have to take credit for.
So with value-based purchase, there is something is going to be replaced. It's the rehospitalization measure. It used to be, or it is, all cause. It's going to be preventable. Here's my advice to you. Work with your providers, your physicians, non-physician practitioners to try and treat people in place when it's appropriate. And of course, any true emergency needs to go, or acute condition that requires hospitalization, you send them to the hospital. But if it's something that's treatable in your facility, work with your practitioners and make sure that you bring that about. Again, this is just the steps of the preventable readmission. Don't know what all those measures will be. Don't know what they're going to consider potentially preventable in every case, and it will change from year to year. The difference really are those practitioners who know how to treat in place. And sometimes there's those simple things, Stacy, that we see is hanging an IV.
Right.
We don't hang IVs. You might want to do that.
Right. And how many times do we send someone out for acute confusion? Did we check their urine? Did we see if they have some sort of infection? What's going on? So really looking at your facility and saying, do we have the capability? Does our staff have the competence to be able to take care of these things at the facility so that we aren't sending them out?
Yeah. This is another that's going to be growing because the federal government, the administration, CMS has told us they're going to work towards health equity and making sure that those that are traditionally underserved have more access to healthcare. And that's good for all of us. That's good for our communities. That's something I think all of us can appreciate. So they will be looking at those facilities and judging to see how many dual eligible residents you have. That means they're eligible for Medicare and Medicaid, and they will be judging based on that, and there will be a penalty or reward. Simple as that. And so, there will be more information coming out on that. And that's certainly your decision on who you're going to take into your buildings, but just know that that is an implication there.
So let's look at what we can do as a leader. So choosing the proper instrument. There are so many free, reliable resources available to you as a leader. So we're going to talk about a few of those. So the CASPER reporting system. Within the CASPER reporting system, you have your quality measures, there's your staffing through your payroll-based journaling, there's survey reports, there's MDS reports, SNF QRP, value-based purchasing. There's so many reports within the CASPER system. When's the last time you as an administrator has accessed them or has had somebody pull these reports for you so that you can look and see what they are? Are you using these quality measure reports in your QAPI system? And that's not just taking them to the QAPI meeting and reporting them, but analyzing the data. Which direction are we headed with these quality measures? Are we headed in the right direction? What can we do to change that? Have we done root cause analysis? Have we trended these quality measures to see if we can see some commonality so that we can figure out and put better care in place, right? That's what our quality measures are telling us. That's what these CASPER reports, they're a way for us to be able to review all of the data that's being reported to CMS, whether it's through your PBJ, your claims, your quality measures, however it is, your MDS, it's giving us an opportunity to analyze those. When's the last time you looked at your CASPER report? Do you know how to pull your CASPER reports? Does somebody in your facility know how to pull the CASPER reports? And are they using them? There's lots of really cool training videos that are out there. Most people don't know that CMS does have a YouTube channel that has training videos. They recently just put out one for the BIMS. The BIMS is not changing in October, but it was something that CMS identified maybe isn't happening as accurately as it should. Let's do this new video. The last one was from like the early 90s, late 80s. So it was older. So it was time for an update. And there's lots of videos, all of the changes that are coming in October. They have different YouTube videos for that. So go check out their page. That's a good resource as well. Have a movie night, have all of your social worker, your therapy, whoever's doing your BIMS interview, have movie night, quick video on what's going on with the BIMS. So directing the orchestra, that's your job as the administrator, is to put all of these things together and provide the tools and resources that your staff need. Are you aware of PHQ-9? Who's doing it? Who's going to do it when it switches to 2 through 9? Are you going to keep it the same way? Are you aware of the QRP and value-based purchasing? Are you aware of the outcomes? Those dashes, let's not have those dashes. Know what a dash is as an administrator and ask, did we have any dashes? Are we going to have any dashes? How can we avoid these dashes? So critical interventions required to realize meaningful change. It's really understanding those rules and programs and then providing those resources to your staff. The time, the education, the mentoring. Have you allowed your staff to go to the education that's provided? It may have a cost associated with it. Is it worth it? As we talked about all of those different programs that you could potentially lose money for, is it worth it sending your staff to a training to make sure that they're competent and come up with ideas along with you on how to execute these changes, making sure that they have the equipment that they need, that ICD-10 coding book, any other equipment that they need to execute these changes.
And we know time is the most difficult thing to allocate. It's the most important thing, though. You've got to take a step back and make sure your processes work. When we talk about mentoring, that's absolutely observing your employees doing the job the way that you know it should be done. So we hope you've enjoyed this. The whole purpose, again, was to take a step back and say, as a leader, how do I assist my team in implementing these changes? My perspective, you got to know the changes before you can support, before you can help them, assist them. You have to take responsibility. And you have to make sure that you're allocating those resources like we talked about. That may have been the most important slide in this whole thing is, what are you doing as a leader to ensure that your team have the access to the resources, the time, and all those things that they need in order to be successful? Just want to let you know that QRM has service offerings, in-house rehab management, multi-claim contractor audits, branding, and of course our MDS services. Want you to stay in touch, reach out if you have any questions. We're happy to answer those. And thank you very much for attending today.
This is not the end of our webinars. We have several coming up this fall. So we do recommend that you visit our event page, which can be found at qrmhealth.com/events. And you can see our stack of events that are coming up with details and registration links. We hope to see you on our next webinar. Thank you and have a great day. Bye-bye.